After 3 years of deliberations, the National Assembly Portfolio Committee on Health has decided to push through the National Health Insurance Bill with hardly a change made to the original version. This despite a threat of legal challenges hanging in the air. For more clarity on this, we are now joined by Dr. Nicholas Crisp, the Deputy Director General in the National Department of Health. Dr. Crisp, a pleasure to have you on the program this afternoon. Firstly, how does the National Health Insurance Bill indeed aim to address this existing two-tier healthcare system in South Africa, and also equally as important, to promote equitable access to healthcare?
Good afternoon, and good afternoon to the viewers. Let me first correct I would disagree that there's been hardly any changes to the bill. The Portfolio Committee has actually made quite a lot of changes to the bill, some of them quite significant, but obviously not everything everybody would like. So I just want people to know that we have observed it. We are, from the department, not part of the political process, but we have observed it, and we've seen quite a lot of changes. Anyway, the National Health Insurance is intended to create one national health system for the country instead of the many parallel structures we have. And in so doing, we would like to achieve universal health coverage, which is a United Nations program that we are part of and that we are monitored by the WHO like many other countries. And what we aim to do is to achieve a situation where we get healthcare for everybody, irrespective of who you are, when you need it, where you need it, and without incurring any financial hardship. And at the moment, we are nowhere near that in this country. Both middle class and wealthy people, as well as poor people, often end up in financial hardship, and many of them do not have access to the healthcare they need when they need it. So the intention of the bill is to bring together, as far as is reasonable and possible, and as quickly as possible, the public and the private sectors, and to stop the segregation between the provinces in the public sector and the 76 medical schemes that fund services in the private sector. But having said that, this is a long-term game. This is not something that happens in the blink of an eye. It is very complicated. There are many different aspects that need to be taken into consideration, and it's complicated funding structures. That's what we are aiming for. And we should end up with what we call in public health medicine a purchaser-provider split, where the funder, the single funder called the National Health Insurance Fund, pays for the services, and the providers in both the public and the private sector are engaged, contracted to deliver the services that are paid for from the fund.
You described the NHI as a long-ended game, but it would seem that this has been in the making for quite some time now. And it's very important for us to understand the key objectives of the NHI bill. Firstly, explain to us, how does it plan to achieve this universal health care for all South Africans?
So let's, first of all, I've been one way or another involved with universal health coverage and NHI for more than 20 years, and many of my colleagues have been at it for as long as that as well. The bill was tabled in 2019, and then COVID held up a lot of the processes. So I heard your introduction saying it's been pushed through. It wasn't pushed through. It was supposed to have been through 2 years ago. So there's no ways it's been accelerated. In fact, it's been held back very significantly by a chain of events. So we're very happy that we've got this far. And what it will do is, once it's law, it will provide an enabling environment for a whole lot of reforms to both the delivery of healthcare and also the way in which we pay for healthcare. What we want is that when a person needs healthcare, they don't have to worry about whether their medical scheme is able to, whether it covers it in the package they've chosen, whether they're going to have to find that money somewhere, whether they're going to run out of money halfway through the year. They will not have to have those worries, because we will have pooled our resources through the taxes that we pay, and the fund will pay for that care when you need that care. There's a lot of inefficiencies in the way we deliver healthcare in the country at the moment. It's hugely inefficient and duplicative. We don't have a common patient record. I can go to a GP, then a dentist, then a hospital, and every time I open a new file, there's no continuity of care, either in the public or the private sector, never mind if I am referred between the public and the private sectors.
Right.
So the National Health Insurance Bill provides the enabling framework for all of that to be harmonized and synchronized so that we have one health system.
In the same breath, can you explain to us how the NHI bill proposes to also integrate and allocate healthcare services between the public and private sectors? And what changes can we expect in terms of this collaboration and resource allocation?
Okay, so you'll see very little changes in the short term. Obviously, these things take a while to come. But where we are headed, in the primary healthcare space, that's in the private sector, mostly general practitioners and pharmacies and other people who work outside of hospitals. And the public sector, where it's mostly clinics and health centers with outreach into patients' homes. That's the space we're talking about.
Right.
What we are working on and what's dealt with in Section 37 or Clause 37 of the bill, which will become Section 37 of the Act, is an integration into what we call contracting units for primary health care, where the GP, together with the pharmacy, together with the clinics in a given geographical area, are providing health care together to a population that lives in that area. This is a common practice that is the model in most parts of the world, and we have unfortunately not followed this model because we've followed this parallel system. In the hospital space, what will happen, if you look at Section 39, or that's currently Clause 39 of the bill, is that providers, both in the public and the private space, will get themselves accredited, much like the private providers do now with their medical schemes.
Right.
They will get accredited with the NHI fund, and then the fund will pay them for the patients that they see. So what you will do as an individual, any South African, you will go to your primary healthcare provider, who may be a GP, it may be a clinic of your choice, and when you need healthcare provided either in a hospital or by a specialist, they will refer you there, and that referred contracted provider will provide you with care. So if you live in Diepsloot, instead of having to drive to Charlotte Macheke Hospital when there's a private hospital literally just down the road, then you will be referred to that private hospital. And the fund will have a contracting arrangement with that private hospital that those patients will not have to travel miles and miles and go and clog up the central public hospital, but will be able to get their health care in the private hospital. We all want this. The private hospital providers, particularly in the example that I've given, have been trying to work with us for a very long time to do this. And at the moment, it's very complicated bureaucracy and incredibly difficult to do. But the Enabling Act that we are talking about will make it a lot easier.
Now, the private healthcare sector has also raised concerns about the NHI bill and its potential impact on the viability of the healthcare business. Could you elaborate on some of these concerns and how are they being addressed?
Yeah, sure. So there's no such thing as the private sector. That's the first problem. There are elements within the private sector who are extremely supportive and are, in fact, engaging with us all the time on the reforms that are necessary. There are parts of the private sector, as you refer to it, who have very entrenched practices whose business models will be disrupted. Now, from a public health perspective, never mind a political or an ideological perspective, from a public health perspective, we do not regard health as a tradable commodity. Health is a public good. All over the world, it's a public good, except here and a few other countries where it has become a tradable commodity. Now, for those who thrive on other people's ill health and make a business out of it, they are going to be compromised. Their business models are going to change and they're going to be compromised. So, for instance, the medical scheme environment will change dramatically over the lifespan of the next 5 or 10 years as we roll out the national health insurance, and they may be more vocal about how they see things unfolding. On the other hand, providers in the private space, particularly the private hospitals, many GP groups and some specialists are quite happy with the national health insurance. The pharmacies have never complained about the way in which national health insurance is designed. And in fact, they've been excellent partners during COVID, and we've learned to work well together. There's also, of course, a huge logistics environment where health products are delivered to provide health care to people. That's also the private sector. They have no problem with what we are trying to do. And in fact, for instance, the Pharmaceutical Task Group, which represents all the pharmaceutical manufacturers and suppliers, works closely with us, and so does SAMED in the medical devices space. So I think I would be very cautious to say the private sector does not like the NHI. There are some who don't like it, but there are many who are extremely supportive and do understand what we are trying to do as a nation.
Questions have also been raised on how will the NHI be funded and what measures are being considered to ensure this sustainable financing. Has the National Treasury provided any clarity on the funding model here?
So we've interacted with National Treasury for many years, and there are some differences of opinion on some details. But we also interact with other countries, the World Health Organization and elsewhere, who have cautioned us, both Treasury and Health, not to try and cost the NHI because these programs take so long to roll out that you are just chasing your tail and not achieving anything. The bottom line is that this country spends 8.5% of our GDP on healthcare. Now, compared with other middle-income countries, that is very high. It's amongst the highest. Most middle-income countries who are more or less our size and our GDP per capita are spending between 5 and 6% of their GDP on healthcare.
Right.
So the starting point is we spend a lot of money on healthcare. The question is, what do we spend it on, and how do we change the way in which we spend that money? So 49% of that current spend is spent in the public sector and amounts to about 5,200 rand per capita per annum spent in the public sector. The private sector is we spent as South Africans 51% of the health spend on in the private sector on about 16-17% of the population, which translates to closer to 27,000 rand per capita per annum. Now, part of the reason why we spend so much money in the private sector is that it's extremely complicated and it's very duplicative, which means you get your lab tests repeated, your x-rays repeated. You have to have a lot of infrastructure and a lot of people to manage 76 different medical schemes,
right,
to reassess all the different options that they give you and so on. If you remove that and we all have one system and everybody knows what the system is, you can save a lot of money. So the challenge is not whether there's money. The problem is how you move the money. In the public sector, it will require a change in the way we budget, and that's dealt with in Section 32 of the NHI bill. And for the private sector, it will require a change in taxes, and that's where everybody's getting their knickers in a knot. It's the same money that we currently would choose to spend on a medical aid, even if your medical aid only covers half of the care that you want, that we would, as individuals, channel through taxes into the National Health Insurance Fund so that we don't have to wonder whether we cover it on the day when we actually need health care.
Dr. Crisp, we have run out of time, but before I let you go, can you provide an overview of the phased implementation plan for the NHI, and how will the rollout occur over several years, and what services will actually initially be offered here?
Yeah, sure. Okay, so the first step is that we need the legislation. We can't start the National Health Insurance Fund until we have the legislation, until a board is appointed and the various committees are appointed and there's a law in which we can operate. Until that time, we have a branch in the Department of Health, which I run nationally, and we have a princely total sum of people of 65 at the moment. We'll be up to about 100 by the end of the year. And we are designing various technical details based on previous work that's been done in research that's been done. That's sort of the foundation. But what we are doing is we are working in building the contracting units for primary health care, primarily now in 9 sites, 1 in each province, with a fully integrated system, including the digital system, and working out on the contracts, how the contracts will work and the payments will work in that primary health care space. That is what will happen in the initial phases of the NHI, is to get the primary healthcare system to work more efficiently. We don't have time to go into all the other details of working with the medical schemes and a single common medical scheme option and so on, but that's all part of that discussion. What we are also starting to work on now is what are called the DRGs, which is a new way of paying, new to South Africa, obviously not new to the world, but a different way of paying for healthcare in the hospital space. That requires quite a lot of data, which is not readily available in the public sector. So we're busy collecting that data, and we'll merge it with what we already know in the private sector space to work out how our diagnostic-related group payments are going to work in the private sector. That may still be 5 years away.
That was Dr. Nicholas Crisp. He's the Deputy Director General in the National Department of Health, speaking to us on these developments regarding the NHI. After 3 years of deliberations, the National Health Insurance Bill has passed through the National Assembly Portfolio Committee on Health.